Good evening, everybody. Good evening to this social media platform. Welcome, everybody, to this national awareness program on prostate. September month is considered as National Prostate Awareness Month. So, we are going to talk about prostate and its various facets, the way physicians deal with the disease of the prostate gland, and almost everything about prostate. Thank you. Welcome, everybody, to this social media platform. We are going today to talk about BPH, that is benign prostatic hyperplasia. Now, what is BPH? Benign prostatic hyperplasia is one of the most common urological diseases amongst the men. It is characterized by benign overgrowth of prostatic tissue around the urethra, which ultimately constricts the urethral opening, resulting in lower urinary tract symptoms. Symptoms associated with LUTS, that is lower urinary tract symptoms, include urgency, frequency, nocturia, incomplete urination, and weak urinary stream. If left untreated, complications such as urinary retention, renal insufficiency, and bladder stones can occur, requiring surgical intervention. BPH has also been associated with other medical morbidities such as increased risks of fall, requiring surgical intervention, reducing the quality of life, as well as increased annual healthcare cost. As such, an understanding of the epidemiology of BPH is essential in health service planning as well as risk factor epidemiology. Now, in general, what do we know about the symptoms when the prostate gland enlarges? The common signs and symptoms of BPH includes frequent or urgent need to urinate, increased frequency of urination at night, which is called nocturia, difficulty starting urination, weak urine stream or a stream that stops and starts, dribbling at the end of urination, inability to completely empty the bladder, that is the urinary bladder. Now, regarding the management of benign prostatic hyperplasia, there are few approaches in the management of medical and surgical aspects of benign prostatic hyperplasia. There is a great saying by Sir Benjamin Brodie. He says, when the hair becomes gray and scanty, when layer of earthy matter begins to be deposited in the tunica of the artery, and when a white zone is formed at the margin of the cornea. At the same period, the prostate gland usually, I might perhaps say invariably, becomes increased in size. This is a befitting saying by Sir Benjamin Brodie with regard to benign prostatic hyperplasia. Now let's talk something about the background of the BPH. BPH is non-cancerous enlargement of prostate. Tissue growth in the prostate gland is controlled by hormones like testosterone and dihydrotestosterone. The prostate is present in mammals, but only two, man and dog, develop pathological changes. Enlarged prostate can cause urinary symptoms. It is common condition in men over the age of 50. What is the surgical anatomy? It develops from the primitive urethra as a series of solid epithelial buds. Prostate is a walnut-sized gland located beneath the urinary bladder and in front of the rectum. The urethra passes through the prostate. The homologue of prostate in females is Skin's tubules. The gland is composed of several lobes that are enclosed in a capsule. So whenever the prostate gland enlarges, whatever symptoms and signs I mentioned earlier develop slowly and gradually over a period of time, and it causes a lot of difficulties. Now, there are few messages for the patients with BPH. Watch what you drink. The most common symptom of BPH is frequent urination. This could mean getting up 4 or 5 times at night to urinate or having to find a restroom quickly when you are out of the house. One way to control it is to steer clear of beverages that make you urinate more frequently. The biggest offenders are coffee and alcohol, so limiting these can really help you. Try to keep your daily intake of all liquids to fewer than 2 quarts per day and drink less from dinner time to bedtime. Avoid some medications, please. Please do avoid some medications. Some over-the-counter cold and allergy medications can make BPH symptoms worse. Decongestant medications like pseudoephedrine, also called Sudafed, and antihistamines like diphenhydramine, that is Benadryl, can both interfere with urination. Some prescription medications can also aggravate benign prostatic hyperplasia. Diuretics used for high blood pressure can increase urinary frequency, and some antidepressants can decrease urine flow. If you are on any of these medications and have BPH symptoms, ask your doctor for help. Now, important is also to reduce the stress. You need to reduce your stress levels. BPH symptoms are stressful enough, but stress and anxiety in general can make you feel the need to urinate even more frequently. Managing your stress can break this cycle. Getting a daily dose of exercise is one of the best remedies for stress and BPH. You can also try stress reducing techniques like meditation, yoga, and focused breathing. Even sometimes, as simple as taking a long hot bath followed by a reading of a good book may help. Follow a prostate friendly diet. I'll tell you what to eat and what to not eat in a case of BPH. Foods which should be taken: a diet rich in fruits, vegetables, and healthy fats is thought to protect the prostate. Specific foods known to benefit the prostate include salmon. It is rich in healthy fats that contain omega-3 fatty acids, which help prevent and reduce inflammation within the body. Other cold water fish, such as sardines and trout, are also rich in this type of fats. Tomatoes may help, are packed with lycopene, an antioxidant that may benefit prostate gland cells. Berries like strawberries, blueberries, raspberries, and blackberries are excellent sources of antioxidants which help to remove free radical from the body, and it also helps to reduce benign prostatic hyperplasia. Broccoli. Broccoli and other cruciferous vegetables, including bok choy, cauliflower, cabbage, contains a chemical known as sulforaphane. This is thought to target cancer cells and promote a healthy prostate. Nuts. Nuts are rich in zinc, a trace mineral. Zinc is found in high concentrations in the prostate and is thought to help balance testosterone and dihydrotestosterone. Citrus. Oranges, lemons, limes, and grapefruits are all high in vitamin C, which may help to protect the prostate gland. Onions and garlic. One study found that men with BPH tended to eat less garlic and onions than men without BPH. Now, some foods to be avoided, of course. What are these foods which should be avoided? These are red meat, then dairy products, caffeine, alcohol, sodium, etc., etc. You need to exercise your bladder muscles. The persons who are suffering from benign prostatic hyperplasia, you need to exercise your bladder muscles. Now, besides urinary frequency, other annoying BPH symptoms include dribbling, leaking, and feeling a sense of urgency. You may be able to control these symptoms by strengthening the muscles around your bladder neck with Kegel exercises, Kegel, Kegel exercises. You may find it out in Google or somewhere else. To do Kegels, contract the muscles that you use to keep from urinating and squeeze tightly for 10 seconds. I repeat, to do Kegels, contract the muscles that you use to keep from urinating and squeeze tightly for 10 seconds. Then relax the muscles and repeat about 10 times. Doing these exercises 3 to 4 times a day may improve your bladder control. Another technique to improve BPH is urinate before you feel the need. Very nice saying. You can you can ease the aggravation of urinary frequency even if you can't get rid of it entirely. BPH makes you feel the need to urinate more often because the condition keeps you from completely emptying your bladder. So when you are out of house and there's a bathroom nearby, take the opportunity to use it. Plan to urinate about every 3 hours, even if you don't feel like to go to. Urinate before leaving the house and before going to bed. Double voiding is another strategy. When it feels like you are done urinating, wait another few seconds and try again. All these techniques just I mentioned may help you improve the scenario of BPH. Now let's go something to the anatomy of the prostate. Smooth muscle cells are found throughout the prostate. Condensation of smooth muscle at bladder neck and base of prostate forms the internal sphincter. Smooth muscle cells are under the control of alpha adrenergic receptors. Prostate tissue produces prostate specific antigen and prostate acid phosphatase. Now, regarding the incidence and prevalence of BPH, 30 million men have symptoms worldwide, and around 10 million people are suffering in India. This is the present statistics. This is the most common neoplastic disease after the age of 50 and rare before the age of 40. Over 50% men above 60 have symptoms. 90% of those over 90 have symptoms. What is the etiology, or what is the reason behind the development of benign prostatic hyperplasia? Exact cause is not known. Condition is associated with hormonal changes in men. Testis produces the hormone testosterone, which is converted to dihydrotestosterone and estradiol. High levels of DHT, that is dihydrotestosterone, involved in growth of prostate tissue. There is one point: castration before puberty is not associated with BPH. Symptomatology, which we earlier, that is called prostatism. There are two types of symptomatology, that is obstructive component, and number two is response of bladder to bladder outlet obstruction. Obstructive component may be dynamic due to increased smooth muscle tone and static due to enlarged gland. What are the symptoms of prostatism or lower urinary tract symptom? There are two variants, that is obstructive and irritative. Obstructive variants are hesitancy, intermittency, poor stream, dribbling, poor bladder emptying. And irritative symptoms are frequency, nocturia, urgency, urge incontinence, and nocturnal incontinence. What are the complications of bladder outlet obstruction? Number one, acute retention of urine. Number two, chronic retention of urine with or without overflow. Number three, impaired bladder emptying. Number four, hematuria or blood in urine. Number five, bladder diverticulum. Number six, bladder stones. Number seven, recurrent urinary tract infection. And the last is chronic renal failure. It's very dangerous. Now, how do we evaluate prostatism and bladder outlet obstruction? There are few procedures. Medical history is very important. Then there is one score recognized internationally, which is called IPSS, that is International Prostate Symptom Score. The total score ranges from 0 to 35. Now, these are divided into three categories: mild, moderate, and severe. Mild category is from 0 to 7, moderate category is from 8 to 19, and severe category is from 20 to 35. Then we can have digital rectal examination, which is a very important part of examination. Then there is ultrasound, kidney, ureter, bladder, and prostate. One more modality is post, to measure the post void residual urine, that is PVRU. This is assessed, of course, by ultrasonography. Normally, it is less than 12 milliliter. It's significant when it's more than 50 milliliter. Bladder dysfunction oblique chronic retention equals to very high PVRU, that is 350 milliliter. Then there is one more modality, Transrectal ultrasound, that is TRUS. Increased rate of early detection of cancer can be done through this procedure, and accurate estimation of the prostate size can be done. Then there is urinalysis, then there are blood tests. Uroflowmetry, this is an important parameter. Initial assessment as well as response to treatment. Maximal flow rate, that is Qmax, is the single best measurement. Qmax more than 15 milliliter per second is considered normal, whereas less than 10 milliliter per second is considered obstructive. Then urodynamic studies are there to differentiate benign prostatic hyperplasia from other causes of bladder outlet obstruction. One significant thing is that prostate specific antigen estimation. This is very important. This is PSA estimation. Its normal range is 0 to 4 nanogram per milliliter. Slightly elevated range is counted from 4 to 10 nanogram per milliliter. Moderately elevated range is counted in between 10 to 20 nanogram per milliliter, and very high is considered in between 20 to 35 nanogram per milliliter. If PSA velocity is 0.75 nanogram per ml per year, there is increased risk of cancer of the prostate gland. Other modalities are cystourethropy. It is to exclude bladder neck obstruction, to exclude stricture of the urethra, to exclude bladder cancer, and to exclude non-opaque vesicle calculus. There is another modality, intravenous urography. It is recommended only in cases of hematuria and history of stone disease. Now, friends, we should go for treatment options. What are the treatment options available in the modern scenario regarding BPH, that is benign prostatic hyperplasia? These are medical treatment, number two, surgical treatment, and minimally invasive therapy. Medical treatment includes watchful waiting, then medications are there, which are alpha blockers, 5-alpha reductase inhibitors, phytotherapy. Then surgical options are there, which are open prostatectomy, then transurethral resection of prostate, which is considered to be a gold standard of surgical approach in the present day scenario of treating BPH. Then there is one thing, holmium laser enucleation of prostate. This is called HOLAP. Regarding treatment, patient selection is to be done. Urologist's aim would be to relieve symptoms, reduce bladder outlet obstruction, reduce complications, improve the quality of life. Treatment is best decided by considering the impact of disease on quality of life. Questions to be answered. Is bladder outlet obstruction present? Number two, how severe are the symptoms and what are the risks of doing nothing? What treatment options are available? Do the side effects justify treatment? Is the man fit for operative treatment? And so. Medical treatment of benign prostatic hyperplasia. What I was telling that watchful waiting is one modality. Most common chosen treatment in mild symptom category, it's around 78%. Patient returns for annual examination. It is assessed by digital rectal examination, then prostate specific antigen and urinary flow rate. Significant deterioration in symptom scores and flow rates over 2 years, if this happens, then BA-US BOS guidelines reviews gives a failure rate of 38% at 5 years. Medicines. These are indicated in mild to moderate symptoms and where there is no absolute indication for surgery. Two classes of drugs that I mentioned earlier. Number one is alpha blocker and number two is 5-alpha reductase inhibitors. Now, what are alpha receptors? These are alpha 1 adrenoceptor, which is predominant receptor type in the prostate. Molecular cloning has identified several subtypes of alpha 1 receptors. Human prostate predominantly expresses alpha 1A and to a lesser extent alpha 1D. Alpha 1B and alpha 1C are predominantly found on vascular smooth muscle. Alpha 1A is responsible for bladder outlet obstruction symptoms, and alpha 1D is responsible for irritative symptoms. So, the question of alpha blockers arises. What does they do? They block the receptors and relax the smooth muscle in the bladder neck and prostate, which increases urinary flow. This is the physiology. Drugs that selectively block alpha A1 and alpha D1 are uroselective, improve maximum flow rate by 20 to 30%, reduce symptom score by 30 to 40%, effects perceived after 3 to 4 weeks. Now I am going to name some alpha 1 blockers. These are short acting alpha 1 blockers like prazosin. It is administered or given 2 milligram orally twice daily. And long acting one is terazosin 1 to 5 milligram administered once daily orally. Subjective improvement observed in 82% of patients. There are few side effects also like headache, dizziness, postural hypotension, asthenia, drowsiness, and sexual dysfunction. What does uroselective alpha blockers do? They selectively block smooth muscle receptors near bladder neck and prostate. Side effects like headache, postural hypotension, and drowsiness are negligible. These are tamsulosin and alfuzosin. Tamsulosin comes by the name of Dynapress, which is administered in the brand name of Alfu. It comes in a tablet formulation of 10 milligram sustained release administered once daily orally. Sexual dysfunction is negligible. Improves the sexual function, that is better quality of life. So in the sexually active males, these type of drugs are preferred throughout the world. Now, what the 5-alpha reductase inhibitors do? Prostate enlargement depends on the potent androgen 5-alpha dihydrotestosterone. In the prostate gland, type 2 5-alpha reductase metabolizes testosterone to DHT. Inhibition of type 2 5-alpha reductase selectively blocks androgen action in the body tissues. This is the physiology. Now, what are the drugs? Finasteride, dutasteride. These drugs are beneficial when the prostate gland size is more than 40 gram or more. These have benefits in decreasing prostate volume by 15 to 20%, reducing the static component, reduces serum prostate specific antigen by 50%. Of course, it has got slow onset of action of 3 to 6 months. Side effects are decreased libido, erectile dysfunction, and ejaculation disorder. Now, these type of drugs are combined for better patient compliance as per MTOPS study. Combination of alpha blockers and 5-alpha reductase inhibitors, for example, Dutas-T, Finas-T, Dutalpha, etc. What are the advantages? Better outcome in symptom control, reduced risk of developing AUR, reduction in need for BPH related surgery, reduction in BPH progression. So nice. Now let's talk something about phytotherapy. It was first described in Egypt in the 15th century, currently used in Europe and is increasing in Western domain or hemisphere. It constitutes 50% of medication for benign prostatic hyperplasia in the Italy, 90% of medications for BPH in Germany and Australia. In the US, it is readily available non-prescription dietary supplement. About 30 phytotherapeutic drugs are being used today. Now, what are the plant extracts used in benign prostatic hyperplasia? African plum. The number 2 is purple cone flower. Number 3, pumpkin seeds. Number 4, rye. Number 5, sow palmetto berry. Number 6, South African stargrass. The number 7, stinging nettle. Phytotherapy in India, in our country. Number 1, sow palmetto. Number 2, African plum. Number 3, lycopene. Lycopene is currently under trial regarding management of the benign prostatic hyperplasia. Now, what are the advantages of phytotherapy? We are seeing a lot of complaints with the other drugs. What are the advantages of phytotherapy? This has got good safety concerns, constant ratio between dose and biological activity, constant therapeutic index. It is devoid of side effects, can be used in patients who are considered unfit for surgery. Just a minute, please. Now, what are the limiting factors in medical treatment of BPH? There are few limitations where you cannot use medications, like postural hypotension, then recurrent acute urinary retention, azotemia secondary to BPH, vesical calculus with BPH, and most important is unstable cardiovascular status. Now, what is the global trend in medical management of BPH? In the USA, what percentage of drugs are used by the patients? I tell you, alpha blockers, which are considered good for the young patients who are sexually active males. It constitutes 85% of the population using alpha blockers, and finasteride is being used by 15%. In the UK, alpha blockers are used by 64% of the population. Finasteride is used by 36% of the population. In the Germany and France, finasteride is used by 20% of the population. Alpha blockers is used by 40% of the population. and the rest 40% are using phytotherapy. So phytotherapy is coming up, and alpha blockers are being used more frequently. Now, persons who cannot be managed with medical therapy, that is, with medicines, they should opt for surgical management. Now, we see that 40% of the patients of benign prostatic hyperplasia require surgery. TURP is the gold standard treatment, that is transurethral resection of prostate, is a gold standard treatment for BPH. Laser enucleation is the emerging new modality. What are the indications for surgery? Number one, retention of urine. Number two, failure of medical treatment. Number three, hydroureteronephrosis. Next is bladder calculi. Then comes bladder diverticulum. Then impaired renal function or impaired kidney function, whatever you say. Then blood in urine or hematuria, and recurrent oblique chronic urinary tract infection. Now, what are the approaches? We'll just briefly discuss. Just let us know. There is one option called open prostatectomy, that is Freyr's transvesical suprapubic prostatectomy. Its indications are when the prostate gland is very large, that is more than 100 gram in weight. When it has got, or when the prostate gland has got large median lobe, when there is associated bladder diverticulum, when there is very large vesical calculus. What are the disadvantages of this operative procedure? Mortality is 1 to 5%. There is increased morbidity and prolonged catheter time, that is 5 to 9 days. Then comes Young's perineal prostatectomy. Indication is when the prostate is large and low lying. Advantages of this operative procedure is low morbidity and mortality. Then comes Millin's retropubic prostatectomy. Its indication is that when the prostate is large and high lying. Then come to the gold standard treatment for BPH, that is TURP, or transurethral resection of prostate. What are the advantages of TURP? It is cost effective, no surgical scar, used in 90% of patients who require surgery, short hospital stay for 3 to 4 days, short catheterization time for 2 to 3 days only, and recovery is very early, within 4 to 6 weeks. Now, there are also complications of the TURP. What are these? Hematuria early and late. Then TURP syndrome is there, incontinence is there, sexual dysfunction is being complained by or found in 30% of the operated patients. Let's come to the newer modality, that is holmium laser enucleation of prostate, or HOLAP. This is the emerging modality of therapy. Indigo laser optic treatment system is used, coagulates the obstructive prostate tissue. Procedure lasts only 30 to 60 minutes. Recovery time is 6 to 12 weeks. Cost is high. Erectile dysfunction, retrograde ejaculation, and incontinence are rare complications. Now come to the minimally invasive therapy. Minimally invasive therapy, where invasion or the procedure involving the invasion is less. These are, I name a few: transurethral incision of prostate, that is TUIP. Next is transurethral microwave thermotherapy. Then comes transurethral nuclear ablation. Then comes transurethral vaporization of prostate. Then come prostatic stents, and then high intensity focused ultrasound. Transurethral incision of prostate is indicated when size of the prostate gland is small, that is 20 to 25 cc. Mild outflow obstructive symptoms are present. Small prostatic urethra, high risk patient for TURP. The patients who are considered high risk for transurethral resection of prostate can be put into this procedure. What is transurethral microwave thermotherapy? A device involved that uses microwave to heat and destroy excess prostate tissue. Temperature utilized is 111 degree Fahrenheit. Procedure time is 1 hour. It is an OPD procedure, of course, does not lead to sexual dysfunction and incontinence. It's a very good procedure. What is transurethral nuclear ablation? It delivers low-level radiofrequency energy through twin needles. No incontinence or impotence is observed. Symptoms take 2 to 8 weeks to improve. Complications include difficult or painful micturition, blood in the urine, urinary tract infections, urinary retention. What is transurethral vaporization of prostate? This procedure uses heated water to destroy excess prostate tissue. Then destroyed tissue escapes with urine through the urethra or gets reabsorbed in the body. Let's come to the prostatic stents. These stents pushes back the surrounding tissue and widens the urethra. Procedure time is 15 minutes and it's done only under regional anesthesia. Tiny spring-like device is inserted into the urethra. Minimal bleeding during and after surgery. Now, high-intensity focused ultrasound is still undergoing clinical trial in the USA. So, these are all the surgical modalities which I have explained in brief. What are the advantages of minimally invasive therapy? It's an outpatient procedure. It's less painful. Recovery is faster. It's done under local or regional anesthesia. Cost is low. What are the global trend in management of benign prostatic hyperplasia? What is the present global trend? In USA, there is 50% drop in surgery. In France, there is 35% drop in surgery. In Germany, there is 25% drop in surgery. In the United Kingdom, no change in surgery. So thank you. Thank you for attentively listening to this program on the management of benign prostatic hyperplasia. And please remember the take-home messages which I had earlier mentioned in this program. Thank you so much.